Okay guys, so I'm just gonna make a quick video regarding all the drugs that we learned in the pulmonary lecture. So I'm gonna just first start with the big picture of what this whole lecture is about. So obviously your lungs have airways which are called what? Bronchioles, right? So they need to stay open, aka patent. So in asthma and COPD patients, the airways are going to be constricted, right? So all the drugs that we're going to learn now are going to just open them. Okay, so let's first talk about why do the airways constrict. So the airways are going to constrict. So constriction is going to be because of this one molecule that starts this all called arachid. Oh my god. I don't know why I did that. Lord. Delete. Okay, sorry. So constriction. So it's all gonna start because of this one molecule called arachidonic acid. Right. So arachidonic acid is going to be the key molecule. So think of it as the key ingredient for these two pathways. So we're going to say this is going to be pathway 1, which is going to be your COX pathway. And then your pathway 2 is going to be your 5-lipoxygenase pathway. So the 5-FLOX pathway. All right, so in your first pathway, so the COX pathway, what's happening is you're going to be making two things, prostaglandins as well as thromboxans. So both of them are going to be causing musculoskeletal inflammation. Okay, so prostaglandins and thromboxans are going to be causing musculoskeletal inflammation. So what's going to stop this? We know it's going to be your NSAIDs. So you're talking about ibuprofen, you're talking about aspirin, so it's going to block this pathway. So now your second pathway, so your 5-lipoxygenase pathway, you're going to be making glucotrions, right? So your glucotrions are going to be causing airway inflammation. Airway inflammation, which ultimately is going to cause what? Bronchoconstriction. All right, so this is going to be specifically your asthma pathway, the 5-FLOX. Why? All right, so we have something called the NSAID trap. So your NSAID trap is when you're asthmatic, so we have an asthmatic patient, and they're going to take ibuprofen or aspirin. So the problem is arachidonic acid can either make pathway 1, the COX pathway, or 5-FLOX pathway. So when you're asthmatic and you take aspirin, it's going to block this pathway. If it blocks this pathway, arachidonic acid is just going to ultimately go to pathway 2, which we said was the asthmatic pathway. So then NSAID trap, you're going to stop the COX pathway. So the COX pathway is going to be inhibited. So your body's going to say, okay, I'll use this arachidonic acid for pathway 2 instead. So now you have flooded the airways with what? Glucotrions. So now you have positive glucotrions in the airways, which is why we say this is the asthmatic pathway. So now you have asthma, you can't breathe. That's why NSAIDs are pretty dangerous for asthmatic patients. All right. So now let's talk more about what's the difference between asthma and COPD. So asthma is going to attack your proximal airways. So you're going to attack your proximal airways, right? So it's going to be the more bigger, more central ones, right? Because it's more central, it's going to be easier to treat. So central, so it's going to be easier to treat. Again, that's going to be your what? That's going to be a bigger, more central airway. So now in COPD, that's going to be much harder to treat. So in COPD, it's going to be attacking your peripheral airways, as well as the lung tissues itself, aka your lung parenchyma, right? So it's progressive, it's irreversible. So really what we're doing here is treating the symptoms, right? So here we're just treating the symptoms. So the cellular pathways for both asthma and COPD are pretty different. So let's first start with asthma. So in asthma, you're going to have an increase of eosinophils, right? You're going to have mast cells. You're going to have CD4, right? CD4 T cells. CD4 T cells, we know we're going to have what? Interleukin 4, 5, and 13. In COPD, it's mostly going to be neutrophils, macrophages. Okay, so it's going to be a lot of them, like way more macrophages. You're looking at CD8 T cells. So you're looking at TNF alpha and interleukin 8. Shout out immunology. Okay, so how does the asthmatic immune response work, right? So to be clear, you're going to have an allergen. It's going to enter your airway. That allergen is going to hit your epithelium, as we said, which would be what? Your lung parenchyma. So from there, the antigen presenting cells is going to go activate your CD4 T cells, right? So those T cells can become Th2, which are going to release what? 4, 5, and 13. So those interleukins are going to activate your mast cells, your eosinophils, which are going to release what? Histamine, leukotrienes, cytokines. End result, you're going to get bronchoconstriction, airway edema, mucus hypersecretion, and asthma attacks, right? So chronically, all this inflammation is going to cause something called airway remodeling, right? It's just when the smooth muscle actually starts to thicken. So smooth muscle thickens, right? What happens when your smooth muscle thickens, right? If it gets thicker, that means diameter is going to get narrower, right? So if your smooth muscle get wider, that means your airways are going to get much, much smaller, which is going to cause less air to get into the lungs. All right. So now let's talk about the 3 types of bronchodilators. So the first one that we're going to talk about is our beta 2 agonists. So this is where we are. We're in our beta 2. Oops. Why is this so big? Our beta 2 agonist right here. So our beta 2 agonist, just think of it being the direct opener, right? So think of the smooth muscle like a fist, and then beta 2 agonists make that fist unclench, right? Because beta 2 acts on the lungs, so it's gonna cause bronchodilation, right? So how does it work? It's like step by step. So first, you're going to have the drug. It's going to bind to your beta 2 receptors on your airway smooth muscle. From there, you're going to have, it's going to activate adenyl cyclase, so AC. From there, AC is going to convert ATP to CAMP. So when you have high CAMP levels, your smooth muscles are going to relax. So your airways are going to stay open, right? So that's the whole chain. It's very, very simple. So if asked for like the mechanism, just know it's beta 2 agonist, adenylyl cyclase. Adenylyl cyclase is going to convert ATP to CAMP. CAMP is going to cause bronchodilation. So the drugs that we have to memorize are mostly going to end in EROL, right? Sorry, I had to stop the video, but anyway, so for beta 2 agonists, you're going to have the drug's going to bind your beta 2 receptors. It's going to activate adenylyl cyclase. Adenylyl cyclase is going to convert ATP to CAMP. High CAMP levels is going to cause what? Your airways to stay open. All right, so there are going to be a couple of drugs that we have to know. So they're going to be your SABAs, your LABAs, your ultralabas, right? So albuterol, this is albuterol, it's in your SABA, so it's going to be the short-acting ones. That's going to be the star, it's the most important one. It's short-acting, around 3 to 4 hours, and it's only used as an inhaler, okay? Salbuterol, which is right here, as well as another name for it is salbutamol, I believe is what the name is for it. It's the same family, as well as levobuterol. So the only one in the SABAs, which are the short-acting ones, is gonna be tetrabutylene. So it is also a beta 2 agonist, but the difference is it's also gonna stop premature labor. So what does that mean? It's gonna relax your uterus. All right, so then you're gonna have your long-acting ones. So your long-acting ones are gonna be salmeterol, R-formoterol, and those can be your long-acting ones. Also, as well as formoterol. So salmeterol, afrometerol, formoterol. It's gonna be your long-acting one. So long-acting, which means what? It's gonna mean 12 hours, right? So with these are always gonna be paired. Paired with a, my lord, steroid. Right? These are always gonna be paired with a steroid. So LABAs. So your LABA, so again, salmeterol, afrometerol, formoterol, just those three are always going to be paired with a steroid. As long as you know that your short-acting ones, so again, salbuterol, albuterol, levobuterol, tertabutylene are your short-acting ones. The rest are going to be your long-acting ones. So again, salbuterol, albuterol, levobuterol, and tertbutylene. So Sal likes tert. Okay? Sal likes tert. That's what we're going to call it. Sal likes tert. So salbuterol. Don't get salbuterol and salmeterol mixed up. Right, so you have their last one, your last beta agonist is beta 2 agonist, I'm sorry. So it's going to be your ultra long acting one. So those are going to be mainly used for COPD. All right. So the mechanisms for whether it's SABA, LABA, or ultralabas, they're all going to be using this exact same pathway. But just know your LABAs are always going to be paired with a steroid. And as you see, all of them end in what? EROL, EROL, EROL. They all end in EROL. So that's how you know it's going to be a beta 2 agonist. Okay, so now let's talk about the side effects for beta 2 agonists. So you're going to get the muscle tremors. This is the most classic thing with beta 2 agonists because beta 2 is also found where? In your skeletal muscle. So it's going to simulate trembling. Okay, so you're going to get trembling. The second thing you're going to get is tachycardia. But you're like, wait, but beta 2 acts where? On your lungs. How can it cause tachycardia? Well, it's going to cause tachycardia because at high doses, it's going to stop being selective and it's going to start hitting your beta 1s, which is where? On your heart. So nothing is actually truly and absolutely selective. It's always going to be dose dependent. So So other things you're going to get is like restlessness as well as hypokalemia. So let's write all this down. So your side effects, you're going to get what? Muscle, tremors, right? That's number one, because as we said, what? Beta 2 is also found in your skeletal muscle. Tachycardia, because what? It being dose dependent. If you go over the dose you need with any of them, you're going to get their drugs not only acting on beta 2 now, but acting on beta 1, right? So then you're obviously going to get the restlessness, hypokalemia. Okay. Why? Because potassium is going to shift into the cells. All right. So again, one more time, your SABAs, sal likes tert. So salbuterol, albuterol, and levobuterol. So sal likes tert. They're ultra labo one, only one. Okay. The only one you have to know is going to be indocterol, right? That's it. Indocterol. That's the only one you have to know. It's used for COPD. All right. So we have to know the selectivity comparison compared to epinephrine, isoproterenol, and albuterol. So we'll get to isoproterenol and like what it does in a second, but let's just talk about the difference for each one. So isoproterenol, so this guy right here, isoproterenol, that is going to be beta 1 and beta 2, which means it's non-selective. When is it going to cause tachycardia? Because of the beta 1. This is always going to be an exam question, he said. So isoproterenol, beta 1, beta 2, non-selective. Because of the beta 1, it's going to cause tachycardia. So now you're also going to have your albuterol. Albuterol is, as we know, it's beta 2 selective. So again, mainly going to get the tremor and headache, but less of the cardiac stuff unless you go over that dose, that safe dose where it doesn't hit your beta 1. And then lastly, we have epinephrine. Epinephrine hits alpha 1, beta 1, and beta 2. So you're going to get all of the side effects for it. Insomnia, hypertension from what? Your alpha 1. And cardiac stimulation from what? Your beta 1. So those are very, very important to know. So as we said, isoproterenol, beta 1 and beta 2. Albuterol is just beta 2. Epinephrine, it's alpha 1, beta 1, beta 2. Okay. So now let's talk about, where is it? Here we are. Your xanthines. So the main drug that we have to know here is going to be called theophylline. So theophylline is going to be a beta 2 agonist as well. It's going to increase CAMP production, right? So thiophyllene is an indirect opener. I'm sorry, I misspoke there. It's going to be an indirect opener. I don't know why I misspoke there. I'm so sorry. So again, xanthines are indirect openers, right? Because we know beta 2 agonists are going to increase CAMP. But thiophyllene is going to take a different approach. What is it going to do? It's going to prevent CAMP from being destroyed. So how does that work? So normally we're going to have this enzyme called what? PDE. What does that stand for? Phosphodiesterase. So phosphodiesterase is going to normally break down CAMP into AMP, which is useless. So thiophyllene is going to block PDE from working, right? When you block PDE, then CAMP can't be broken down, so CAMP's going to stay high. So it's going to be the same end result as beta 2 agonists, but just achieved a little bit differently. So as we know, this drug is going to block PDE. So theophylline is going to block PDE. So It does have a secondary mechanism that we should talk about. So its secondary mechanism, it's also going to block adenosine, right? It's also going to block adenosine. So adenosine causes bronchoconstriction by triggering histamine and leukotriene release. So remember this pathway here? Pathway number 2 is going to release leukotrienes, right? So it's going to cause what? Bronchoconstriction, which is the asthmatic pathway. So we're talking about the 5-LOX pathway. So adenosine is going to cause bronchoconstriction by triggering the release of histamine leukotrienes. So if you block if you block adenosine, you're going to get less bronchoconstriction. So that is how diethylphylline also causes bronchodilation by blocking adenosine, right? So now we have to talk about the connection to erectile dysfunction drugs. So it's also a PDE5 inhibitor. So, PDE5 inhibitors are found in Viagra, cellulase. We don't have to know that in the exam, but it's going to be the same mechanism. It's going to block phosphodiesterase, right? But in blood vessels instead of the airways. So blocking PDE in the blood vessels is going to cause vasodilation. That same enzyme, different location, different effect. So if you see PDE in the blood, in the lungs, bronchodilation. In other areas, Viagra. Okay, so it does have a specific dose that you can use it for. So there's something called your therapeutic dose. So your therapeutic dose, it's very, very critical. So below 5, so if it's below 5, it's not going to work. So it does not work. But below 5, it does not work. But if it's above 15, it's going to be toxic. Okay, so you don't want to, so if the exam's like, oh, we have diethylphylline above 15, is it toxic? Yes, no, yes, it's toxic. All right, so now let's talk about the factors that affect clearance, right? So these are the things that make the drugs leave faster. So it's kind of hard if you take these drugs, it's going to be harder to keep them in range. So these are going to be called your enzyme inducers. Okay, so your enzyme inducers, you're looking at RPES. So rifampin, you're looking at phenobarbital, ethanol, and smoking, right? So drinking and smoking. So the two drugs, though, they're going to be enzyme inducers, rifampin and phenobarbital. So you can also have high protein diets and barbecued meats, and also if you're a child for some reason. So it's like age. So high protein diet and barbecued meat can also increase clearance. So things that decrease clearance are going to be actually cimetidine is actually a drug for, I believe, not peptic ulcer disease, but I think it's mostly for increased acid production. But regardless of the fact, it's something along that realm. But then obviously we know about the last erythromycin and ciprofloxacin. Those are 2 antibiotics. So those things are going to decrease your liver, the decreased ability to clear out these drugs. So what's going to cause toxicity. So other things that can cause it is going to be chronic heart failure, liver disease, because you can't process or clear the drugs, obviously, or if you're sick. So if you have a viral infection, if you have a high carb diet, or if you're in older age. So very much different. So to keep drugs, enzyme inducers, so it's going to increase your clearance. What did we say it was? It's going to be a high protein diet, right? Smoking, whatever. But to decrease clearance, so toxicity, you're looking at a high carb diet. Okay, so Side effects are when you take thiophyllene above 15 milligrams, you're going to cause things like seizures because of CNS excitation. Remember that thiophyllene is a xanthan, right? So xanthans is pretty much from caffeine, right? So xanthans are going to cause CNS stimulation, increase sympathetic activity, causing what? Tachycardia and seizures, right? You're going to get the tachycardias, the palpitations, the arrhythmias, nausea, vomiting, GI upset. You get hypotension, right? So just think thiophyllene, the same things, the same side effects you get from drinking too much espresso. You're going to get the exact same side effects with thiophyllene when it's toxic, right? So you can't use it. So when you have peptic ulcer disease, thyroid disorder, seizure disorder, right? Because obviously when you're, even with 15 milligrams of thiophyllene, you can get a seizure. Or if you have coronary artery disease. So that covers that part. So now let's look at our anticholinergics, right? So your anticholinergics are going to be the acetylcholine blockers. So these are going to work in a different mechanism completely. So you're going to be acting as what? Your parasympathetic nervous system. So the concept is that acetylcholine is your parasympathetic neurotransmitter that's going to bind what receptor? Your muscarinic receptors. Where? In the airways. It's going to cause bronchoconstriction and increased secretion. So the anticholinergic drugs are going to block your muscarinic receptors. So where are they going to sit? They're going to sit on the receptors, and it's going to be like a plug stopping it from binding. So there's only one drug that we have to know, and it's going to be called ipratropium bromide. I don't think I have it here, so let me just write it here. So it's going to be your ipratropium bromide. All right, that's the only drug we need to know, which is what did we say it was? It's going to be an anticholinergic. So it's going to be your ACH blocker. So if you block the muscarinic receptors, ACH can't bind. This is all in the lungs, can't bind. So you're going to get decreased bronchoconstriction, right? So that's going to be your ipratropium bromide. Okay, so it's going to be the only anticholinergic that we have to know for the respiratory system. So it's going to be given as an inhaler. All right, an inhaler or a nebulizer, actually. I forgot about that part. It's going to be a nebulizer. All right, so it takes around 30 to 60 minutes to work. It's going to last around 6 to 8 hours. So the thing is, you're never going to use ipratropium bromide for acute attacks. So never use for acute attacks. Jesus, I can't spell to save my life. Attacks. Right? So it's only going to be used for maintenance and chronic use. So it's going to be chronic and maintenance. Right. So usually they're going to combine it with albuterol. That's just going to be an additive effect. So it's usually combined with albuterol. Okay. So that's going to be your ipratropium bromide. So combine it with albuterol just for that additive effect. Okay. So for COPD specifically, your anticholinergics actually can be as good or even better than beta-2 agonist, right? Because they're going to inhibit what? They're going to inhibit your vagal tone. Your vagal tone. So they're going to inhibit your vagal tone, right? So, which when you inhibit your vagal tone, it's gonna cause a much bigger role in COPD management. So, increase role in COPD management. Okay. So, you have another drug, and it's going to be the long-acting version of ipratropium bromide. It's going to be called tiopromium. I believe I have it. Oh, I actually had it here as already. So ipratropium bromide versus tiopromium. What's the difference? The difference is that tiopromium is 2 times the duration. Use it once daily, preferred for COPD. Okay, the classic anticholinergic. So the thing is the side effects of anticholinergics gonna have a bitter taste, dry mouth. The drug usually dries up secretions, urinary retention, glaucoma risk, and increased heart rate. All right. So now, now let's talk about the anti-leukotrienes. So anti-leukotrienes, they're gonna block inflammation at the source. So if we're gonna go back to the arachidonic acid pathway, we can see instead of just opening the airways, we're gonna say, why not just stop leukotrienes from forming in the first place? So what pathway are we looking at? We're looking at pathway number 2, the 5-LOX pathway. So again, we're looking how arachidonic acid, right, it's gonna go through the 5-LOX pathway, and then you're gonna have like a couple of enzymes which are really not that important. Looking at LTA4 branching into LTB4, right? LTB4 is just going to be for neutrophil chemotaxis, etc., etc. So there are going to be 2 ways to block this 5-LOX pathway. So just know arachidonic acid 5-LOX. That's what this anti-leukotrienes are going to do. So here we are. So 2 ways to block this. You have 2 drugs, right? The 2 main ones that we're going to be talking about. And if you look at what they end with, they're going to end with Lucast or Lutron. Sorry, my little osmosis watering thing is in the background making me water, if there is any background noise for that. But okay, anyway, the 2 ways to block this. So the first drug that we're going to talk about is going to be Xyluton, right? AKA Zyflo. So Zyflo is going to block 5-lipoxygenase itself. So 5-FLO/FLAP, right? So we're going to block 5-FLO. Let's just to just complete this whole thing, we'll also say FLAP. It's going to stop 5-FLO and FLAP, right? So that's the enzyme that's going to start this whole leukotriene cascade. So it's going to work upstream, right? So if you're working upstream, it's like stopping the factory before it even makes the product. So Xyluton is going to stop everything from the start. Your second drug is going to be Montoclast. So Montoclast, one name for it is going to be Singulair. Another name for it is going to be Zephyrlucas, which is AKA Acloclat. So they're going to block something called cis-LT1 receptor. So your cis-LT1 receptor, right over here, cis-LT1 receptor. So where are these found? They're going to be found on the airway cells. So those are going to work downstream. So again, the leukotrienes are already made, but they can't attach to the receptor that caused the damage. So these are the receptors, right? So now the leukotrienes can't bind the receptor. Okay, so that's going to be anti-leukotriene. So I have a weird mnemonic zoomase for it. So you're looking at Xyluton, Montoclast, and saproleucast, sorry. So again, or you can also say ZMZ. So xyluton, and then the two last ones that end with class are going to be the same ones, but montoclass is going to actually be singular, and then zaficlast is going to be accolate. So the two ones that end with class are going to block the receptor. So your CYSLT1 receptor. So now leukotrienes can't bind, so this is downstream effect. And then xyluton is going to block 5-flow/flap, which is the upstream effect. So you're not going to be making any be making any leukotrienes. Okay. So the key points for this, these drugs are gonna be used what? They're gonna be used for all anti-leukotriene drugs. They're gonna be used daily, right? For what? Chronic asthma prevention. So it's gonna be for chronic asthma prevention. Not for acute attacks. So not for acute attacks. All right. So monoclass is actually approved for kids as young as 2 years old. So if we get a question saying like, oh, we have a 2-year-old with chronic asthma and we want to prescribe something that's going to act on the receptor site, what can we use? You're going to use monoclass. So regardless, so all these anti-leukotrienes are going to have much fewer side effects than any steroids or theophylline. Remember what we said theophylline was? Theophylline is going to work like a beta-2 agonist, but what does it actually do? It's going to go inhibit, right here, it's going to inhibit PDE, which does what? Break down CAMP. All right, so obviously there's going to be brand names. I really doubt he's going to test us on, but again, singular is monoclass, Zyflo, xyluton, accolate is going to be zaficlast. All right, so now let's talk about our corticosteroids. So corticosteroids are going to be your gold standard for chronic asthma. So gold standard for chronic asthma. Oh my God, I really can't spell. For chronic asthma. So these are also called your inhaled corticosteroids. So i.e. your ICS, your inhaled corticosteroids. So they're going to be your first line of treatment. So why are they so powerful? So most anti-inflammatories block 1 or 2 cytokines, right? But corticosteroids, they're going to work on the gene level. So corticosteroids are working where? They're working on the gene level. All right. So they're going to shut off transcription on multiple inflammatory genes simultaneously. So here, I'm going to just say the simplified mechanism for all of this. So normally, inflammation is going to activate what? Inflammation is going to activate NF-κB. So it's activated by inflammation, right? So that's going to be your master switch protein. So then NF-κB is going to turn on your inflammatory gene. So turns on, oh my Lord, inflammatory genes. So what is that going to produce? It's going to produce interleukin 1, 4, 5, TNF alpha, whatever. All right. So now you have to understand that corticosteroids are going to activate your glucocorticoid receptor, right? So your GR. So that's very important. So your corticosteroids, they're going to activate a receptor called your glucocorticoid receptor. So GR. Okay. So GR, right here, glucocorticoid receptor, is going to travel to the nucleus. So it's going to go to the nucleus. right, it's going to recruit an enzyme. What is this enzyme called? It's going to recruit an enzyme called HDAC2, right? So HDAC2 is going to go and turn off what? It's going to go and turn off your inflammatory genes. So the result is going to be massive suppression of the entire inflammatory cascade, which is why corticosteroids are always going to be the gold standard. All right, so they're going to block what? Your T lymphocytes, your macrophages, your mast cells, eosinophils, dendritic cells. So basically your entire immune system. So let's talk about the drugs, right? All the drugs are going to end with zone or onide. So some of the drugs, so the main drugs that we should know specifically for injection as well, for inhaled corticosteroid drugs to know, it's going to look at so it's going to look at beclomethasone. You're looking at triamcinolone and dexamethasone, right? So beclomethasone, dexamethasone, and triamcinolone. So your triamcinolone, that's going to be the only commonly injected one in the foot and heel. But you should also know those three can also be injected. But the majority, you can also inhale it. But those three, the beclomethasone, dexamethasone, as well as triamcinolone, are all, I cannot say that word to save my life. They're all going to be known for injections as well. But the main one you're going to use is the one I can never pronounce, triamcinolone, right? Maybe that's correct. Who knows? All right. So then you're going to have, obviously, your fluticasone, right? As well as your, right here, so your fluticasone, as well as your budesonide. I can never say the corticosteroid ones. Sorry. But again, it's going to be your fluticasone, as well as your budesonide. So those are going to be combo inhalers. Right here, those are going to be your combo inhalers. Sorry. And those combo inhalers, they're going to be Advair and Symbocrat. He didn't really talk much about them in class, but just know them. So your Advair is going to be fluticasone plus salmeterol, and then your Symbocrat is going to be budesonide plus formoterol, right? So the side effects is going to be obviously for pharyngeal irritation, cough, dry mouth, oral fungal thrush. So an oral fungal infection. Why? Because it's going to locally suppress the immune system, as we said. So if you're going to locally suppress the immune system in your mouth, so your normal fungal flora is going to overgrow, right? So they usually tell you to gargle and rinse every day. Okay, so let's talk about the systemic side effects for it. So when you give it orally or IV long term, in class, the professor did say, think of it as 3 macronutrients, and steroids mess up all of them, right? So carbs, right? So when you take carbs, steroids will actually raise your blood sugar, which will cause you diabetes. So if you take corticosteroids and you eat a lot of carbs, they're going to raise your blood sugar, going to cause diabetes. If you eat protein, steroids will break down the protein, causing muscle weight sting. If you eat a lot of fat, steroids will cause fat redistribution and atherosclerosis, which can cause CHF as well as hypertension. You also get things like psychosis, anxiety, peptic ulcer disease, osteoporosis, immunosuppression, obviously because it's gonna suppress your immune system, and cataracts, as well as weight gain because of it increasing your blood sugar, decreasing your protein, and increasing your fat. So important things to know about your inhaled corticosteroids besides the fact that the three for injections, the beclomethasone, the dexamethasone, and again, the trimicanolone, this guy that I can't say. But so a few things you have to know for them, for all of these meds, right? So ICS, again, first line of chronic asthma drugs. So first line, the gold standard, it's not for acute attacks. So long-term oral steroids are going to suppress your own cortisol production. All right, so if someone's been on steroids for over 2 weeks and has surgery, you must give extra steroids. Otherwise, they can go into hypotension because their body has stopped making it their own. So again, if you have a patient and you, before surgery, you always have to ask them, are you on any corticosteroids? How long have you been on it? They say for over 2 weeks. On the surgery table, you must make sure to give them a dose of a steroid. Why? Or they will get into hypotension because the body has stopped making their own cortisol, which is going to cause them to what? Die on the operating table. So even 2 weeks of corticosteroids can make someone immunocompressed. So they're not to be messed with, but if you have chronic asthma, sadly, this is something you have to use. And as well, we'll also use it a lot for injections. So again, what are they? Beclomethasone, dexamethasone, and your trimicanolone. So it's going to be your BDT. So instead of BLT, it's going to be BDT. All right, whatever. Okay, so now let's talk about your mast cell stabilizers. So your mast cell stabilizers, thank God it's only 2 of them. It's going to be cromolyn and nitochromil. So all those are going to do, they're going to stabilize the mast cell membrane so they don't release their inflammatory cytokines. That's it. They're going to, So all they're going to do is stabilize your mast cell cytokines, can't release inflammatory contents. That's it. Right? They have no direct bronchodilating effect. That's it. It's just purely prophylactic. So this is just prophylactic. That's it. That's all that it is. Oh my Lord. Prophylactic. All right. So it's not really used today. You can find it mostly over the counter, not for acute attacks as well. So again, the 2 CN mast cell stabilizers, cromolyn and then nitochromil. So that is everything that we have to know for the pulmonary lecture. So yeah, I hope this helped. And if you have any questions, obviously, I will be more than happy to help. This is my first time really making a video, so I hope I did a good job. Okay, thanks.